ACEs and also other trauma disclosures. Next slide. Just as a quick reminder, we've conducted 3 other webinars, and you can find those recordings on our website. We can also add them to the chat at some point. I can do that. And then we have 2 more sessions after this one. The last one is still to be determined. If there's a topic, a special topic that you're interested in that we haven't covered, please feel free to chat to us during any time really during the session, and we can make a note of it. If not, we have a lot of things that we are anxious and eager to present on, so it won't be a problem if we don't have a lot of suggestions, but obviously we'd love to hear what everyone is interested in. Okay, next slide. So I don't want to take up too much time on this, especially for those of you who have been with us for the last 3 webinars, but just briefly, my name is Yael Lipton. I'm a trainer with Primary Care Development Corporation. I am a health educator by training and spent really the first half of my career providing direct services to in underserved communities through federally qualified health centers and reproductive health clinics, mostly in New York City. Our organization is based in New York City, but we have a California office and we're national. So that's how we're involved in the ACEs Aware work. So I do a lot of work around trauma. I do a lot of work around health literacy, care management, team-based care, and really stuff around person-centered care, which is all very similar. So thank you so much for being here. And I'll just let Angela introduce herself briefly.
Hi, everyone, and Happy New Year. It's great to be back, and just very quickly, for those of you who have not met me before, like Yael said, my name is Angela Fernandez. I am currently the Assistant Director for Mount Sinai Hospital Sexual Assault and Violence Intervention Program, which is based here in New York City. I also started my career as a public health educator, specifically in sexuality education, which is where Yael and I met many years ago. And really, started that work focusing more on the prevention side with reproductive health and sexual health issues, and started to really build my experience in program development. And then that just really kind of took me on a path to get more involved specifically in trauma work and specifically around sexual violence and intimate partner violence. And again, with a focus on prevention in the education aspect, but also more hands-on with direct service systems and improvements, and specifically working with professionals who will be supporting trauma survivors in a healthcare setting. So really thrilled to be back here again with all of you today. And thanks, Yael.
Sure. Just as a reminder too, Kimmy, who is kind of our behind the scenes person, is helping us out. And you'll also see Amy Goodman, who is one of our experts in small practice management and operations. So she's also on hand to answer any questions that we cannot answer and be a support to us as well. All right, next slide. So what we're going to cover today is really all around screening, how to set the stage for screening, how to figure out which of the tools you want to use for screening, thinking about best practices for screening. And then we're going to spend a bunch of time talking about how to actually respond to trauma disclosures. And then what are treatments? What are the treatment modalities and the responses that we should be using with people? Okay, next slide. So if you've been on here with us before, we love to start off with a real case study. So I'm just going to read this, and there's a couple of questions at the end. We'd love to hear you, but we'll have to just take you typing into the chat box your responses, and everyone can follow along, and I'll try to read them out loud as well, as long as they don't come in too quickly. So Ralph is a 50-year-old male patient who is living with type 2 diabetes, heart disease, and depression. He has been a patient of your practice for the last 15 years. Staff described Ralph as moody but kind. He goes through periods of time when he misses a lot of appointments, and then times when he comes more often and expresses genuine interest in controlling his chronic medical conditions. He has been taking antidepressants for years and generally adheres well to those, as he says he cannot function well without them. However, his diabetes and heart disease have been uncontrolled for the most part, with short periods of control every now and then. Your practice has just gone through the ACEs aware training and are ready to begin screening. Ralph comes in about 2 months after you have started screening. So what would be the benefits, do you think, of screening Ralph? Any thoughts? And you just have to, you'll have an option, I believe, right, Kimmy, to chat to all panelists and attendees. So if you want to do that, that's great.
Yeah, that would be great, just so that everybody can see.
Yep, establish a baseline. Okay. Any other thoughts? Understand the context of his life would be a benefit, absolutely. Monitor for changes. What should happen in terms of the process for screening Ralph? How would screening take place? So somebody writes to see whether trauma is, all right, going back up here, to see whether trauma is interfering with day-to-day adherence, assess for history of traumatic experiences. He has been compliant with treatment and his disease has been uncontrolled. Okay. Yeah, so it seems like he generally takes his antidepressants, but not so much with his physical, right? His physical health issues. Yeah, so I mean, everything you guys said is true. You know, since we know that people who have experienced trauma, you know, are greater risk and more likely to have things like heart disease and type 2 diabetes, and especially because it hasn't been well controlled, you know, we really want to try to see if there's a connection there, right? And if there is a connection, we want to try to treat the trauma or address the trauma and do some education with Ralph around the connection potentially between his the past, his trauma or current trauma for that matter, and his physical health. So what would happen in terms of the process for screening Ralph? Any ideas? Okay, we'll move on. We'll keep that open. So screening should take place at start of clinical appointment, provided screening forms when he checks in and nurse reviews, answer and notes severity of risk. Okay, so that's absolutely one potential like process or workflow. Thank you. I don't know if I'm going to pronounce your name, if it's Ada or Ada, but thank you so much. All right, let's go on. Next slide. So how do we set the stage for screening? So like most new programs or screenings or really any type of new protocol, there's a lot of preparation work that needs to happen. And we hope that obviously by participating in some of the webinars and some of the other things that have been going on in California, some of that pre-work has really been completed. So let's dig into this. Next slide. Okay, so setting the stage, you know, engaging all staff. So really all staff need to understand what you're doing, why you're doing it. When I say you, I mean the practice. And then specifically, obviously, what is their role going to be? It's even better to include staff in all the planning as they really know best, right? How things are going to affect their work and then how to make this new process potentially work. You need to decide which tool or tools you're going to use and the format. So are you going to be using paper? Are you going to be using some sort of iPad? Are you going to use the electronic health record? We're going to talk a little bit more about this, but it's clearly obviously important. So if you're using paper screeners, you know, how are you going to do that? Are they going to fill it out on their own? And then if somebody scans it into the electronic health record, assuming you're using electronic health records. So this doesn't mean that you can't change your approach, you know, based on what's working and what isn't. So thinking about where patients will complete the screening, assuming they're completing it on their own, and having multiple options. Obviously, this is kind of space dependent, but if you're a smaller practice and you have a small, perhaps crowded waiting room, people may not feel comfortable filling out, the screening next to others. And then do you have a place where they can do it privately? And if not, how do you plan around this? So offering assistance and avoiding assumptions about who might need assistance in filling out the form, right? Many of you who have been with us before know we love to talk about health literacy, but are the forms understandable, right? Is your screener understandable? And, we don't really know who has health literacy challenges. So if we're offering help, really, we want to probably offer it to everybody. And really then knowing your community resources for trauma treatment, for support, for things like housing, food, legal, right? We cannot do the screening if we don't know how to respond or have places to be able to refer to. And then consider having health literate material about the connection between trauma and health in the waiting area. All right, next slide. Okay, so preparing patients and families. So explaining the rationale or the benefits of screening ahead of time, if possible. This isn't always possible, whether or not it's through a reminder call, a text message, and obviously right before you give the screening to them. In some cases, repetition is not a good thing, but in this case, it probably is a good thing. Remember that many people will really not be used to healthcare asking them these questions, or maybe anyone asking them. So it's really important to explain why you're asking and then how the information will be used. I think sometimes we do the why, but we don't do the how. And then obviously if a patient has concerns or expresses apprehension, assure them that they don't have to participate. Obviously, while we hope people will participate, they really don't have to. And if they don't want to, you may want to make a note, obviously let the provider or the clinician, whoever is going to, go over the screening tool with them, that they didn't want to participate so that other people, can ask, what if there's, something that they could do, or, what basically, why don't they want to participate, and saying it's okay. And also asking, obviously, if you can revisit with them later. Okay, next slide. So obviously this is a really important part of screening and probably one of the things that we've heard the most challenges around. So the screening tools that you're going to see and the screening tools that ACEs Aware put out are paper tools, right? And if we are using paper, we need to be able to get it somehow into the electronic health record. And also we have to get it to the provider or the person who's going to be addressing the screening before they actually see the patient. And I know that sounds kind of funny, but we were recently talking to a practice and that was their main problem, was that they were doing all the screening, but they just were somewhere in the process of the results getting to the provider before the patient got into the room. Was a challenge for them. The other thing I want to note is that there is some work being done around getting the screening into electronic health records. So you can check the ACEs Aware website for more information on this. If you can't find it, you can shoot me an email and I can kind of reach out to the people who are organizing around what are the organizations that are working on this and kind of what's the timeline. And I know they're not doing it with every single EHR, but they're doing it with a small handful of the most common ones. Okay, next slide. Oh,
that's me.
I think did we go? Oh, I think there was one before. Can we go one back? Oh, I have the wrong. Okay, good. Now you're on, right, Angie?
That's me.
Thanks. Go next. Sorry, I got confused with everything here.
Oh, I know. It's so many different formats and also tech devices, so I have a hard time keeping track as well. So thank you so much for that. Yael set us up really well to go into this next section. So why screen, right? We thought that we should revisit this, although we did do a pretty comprehensive first session on just the impact of trauma and the connection, right, between traumatic events as young people and the lifelong impact it has on our health and well-being. So, but we wanted to just go through this really quickly again about the rationale and the benefits of this. Next slide, please. So, number one, I think that we really would just want to emphasize again around going back to what trauma really does to a person, right? And that it can really manifest in a lot of different ways, but really it completely shifts the worldview, right? And the experience of for a person walking through the world, right? It really impacts us as like the entire organism, so to speak. One rationale and benefit of screening is that this gives us an opportunity to potentially help to contribute to shifting this worldview for people who are walking around with trauma. And so we're moving from this place of a trauma view, which really is all about feeling unsafe, feeling insecure, feeling that the world is, really unreliable, and threatening. And also for that person who has trauma history, oftentimes the struggle is that self-regulation of being able to exist in this world that has all of those elements in them, right? So the trauma view really is one where the world is unpredictable, that there's a sense that people can't be trusted, that they can hurt you, that it's not a safe place, that help and support is not available, that a person's self-worth and really their own self-view is very negative, and that there's a hopelessness to that, right? That things won't get better, things can't get better, there's no hope to get better, and this disconnection with oneself. So not just a distrust of others, but really a feeling of distrust, or really a removal or disconnection from being in your own body and knowing your own self. And that most of the time, embracing feelings means that there will be pain, right? And so oftentimes a reaction to trauma is to really hide from those feelings. So there is an element of secrecy, not just about the traumatic event itself, but almost a secret from oneself that something has happened. And we want to shift that to a world view and an experience in it where there is predictability, there is security, there is safety, right? And that each one of us really does walk around with a set of protective and strength factors that we have. And part of moving that secrecy for a person with trauma in their history is to really be able to reflect the reality of that person's strength and resilience with them, right? And it's definitely a process with a person. We obviously can't undo what has happened to a person, but we certainly can do our part in opening up pathways to a better experience in life. Next slide, please. So, I'm not going to go through this entire list, but just to emphasize that trauma really does affect us and affects people as in their entirety, right? So we're going to see this reflected in chronic health conditions and in disease. We're also going to see this in possibly behavior. We're going to see this in social interactions and relationships, and also in mental health and wellness and behaviors as well. Next slide, please. And as just a quick reminder of bringing us back to those ACE findings from the study, and really what brought all of us together here today is that we know the higher the ACE score, right, the more types of adverse childhood experiences a person has had and reports, we know that increases the risk and the likelihood of developing some very serious chronic health conditions, and probably a lot of the conditions that you all see in your practices among your patient populations right now. So the list is here. It's not exhaustive, but just if we take a look at some of the numbers here about how much more likely it is to develop some of these things, it's pretty astounding, right? So obesity, depression, diabetes, drug abuse, and then also attempted suicide. So it really runs the gamut. And so we can really say, you know, that experiencing trauma early in life is can, you know, lead to an earlier death. Next slide, please. And that, you know, there have been a lot of studies that just show how impactful childhood stress is and how it truly does change the physiology of our bodies early on. And so when we look at risk factors effect on life expectancy, and you think really about the emphasis on some of these, you know, on changing health behaviors over the years. So, you know, we've gone through a huge shift in smoking cessation and really being able to identify and have proof of what smoking does to our health, right? Obesity, high blood pressure, we're in this now with diabetes. And then you look at the effect on our life expectancy that childhood stress can have. And again, I think that this is truly the all the rationale we need for why screening can really change people's lives. Next slide, please. And the benefits of screening, right, are not just for the patients, but also for providers and the practices themselves, right? So, so essentially or theoretically with screening, if we do it, you know, if we do it consistently and we do it well, that we can provide earlier interventions. And we know that earlier interventions, right, will lead to the likelihood of better outcomes. It also, the screening may help to explain the why behind certain physical or mental or behavioral health issues, right? And so many patients really are searching for that why, right? Why is this happening to me? Why does this happen? I think the medical healthcare system, we're really good at identifying really what, you know, the what, but this is really helpful in the why in disease development and progression. Providers can perform a more accurate risk assessment and then proactively create a plan with patients. So it just gives us that fuller picture. And I think some of you mentioned that earlier, right? We get to know the whole person. We can target our prevention education and initiatives to be more effective when we can really hone in on what's really going on. The screening itself can help to gain trust and collaboration with a patient. It really shows that we're invested in learning about a person and knowing and understanding their experiences and what that might mean for them. And it will also open up a door for us to have more, you know, strength-based conversations with patients to really be able to identify what protective factors and behaviors do they already have right now, and how can we use that and leverage that in addressing some of these other chronic health conditions. And then, you know, at the end of it, the benefits of screening and really the rationale is that, you know, ultimately what we're trying to do is reduce human suffering. And walking around with trauma history and not having the opportunity or even the awareness to be able to, you know, remove that from this kind of darkness is it's suffering, right? And people are suffering. And this is an opportunity for us to do something about it. Next slide, please. And this is just really shows, right? Screening will also add, in addition to and lead us to mobilization of community resources, right? So for definitely, this doesn't mean that we screen in our practices and then it's all on us to do something about everything, right? But this is another opportunity to connect to additional support resources. And there really are a lot of them out there. And all of that together really can improve patient outcomes and quality of life. Next slide.
Okay, so now we're gonna talk about some of the nuts and bolts of screening. We're gonna go over a little bit about billing. So next slide. So this information, just so everyone knows, comes directly from the ACEs Aware website, and you can get more information on that website. I just wanted to go over some of the key points. So if a practice wants to bill, a provider must, or the providers must complete this 2-hour online training. And then there's basically a form that you go into and attest that you've completed it and basically say, I've completed it. Once you do that, you actually you can bill. It's $29 for each screening. It's only for patients with Medi-Cal, and we're actually going to talk about that a little bit later, about how that can be a challenge in doing this work and screening and responding. You have to document the following: the screening tool that you used, that the completed screen was reviewed, what the results of the screen were, and interpretation of the results, and what action was taken. Next slide. Here are the billing codes, which actually differ between a lower and a higher ACE score. So my sense of why they want to do that is because they're actually collecting data on who, like what, right, who is carrying the heaviest burdens of trauma, because this is all part of, you know, collecting information and being able to disseminate it. And in terms of the frequency of screening for people who are under 21 years old, the website basically says, the Surgeon General says, you should do it as needed, but you can't bill for it more than once a year. So you are allowed to bill for it once a year. For adults who are 21 to 64, you can only bill for it once in the lifetime, which is actually a shame, but right, small steps here. And after age 64, people are going on to Medicare, which is currently not part of this program. I don't know if the hope is that it will be, but I'm assuming that the hope is that it will be, because it obviously needs to be, right? The results of trauma don't just end at when you're 64 or you stop experiencing it, that we all know. Okay, next slide. So putting it all together, what does the screening workflow look like, or what could it look like? Next slide. So we're going to go over some potential, or really a potential workflow. This is a suggested workflow from ACEs Aware, and then we've tweaked it a little bit, also depending on based on our experiences. These are suggestions, right? This is not the law, so to speak. You obviously have to find a workflow that works best for your practice, but I think it's still helpful to see, you know, some examples and consider these kind of a starting point. So next slide. Okay, hopefully everyone can see this. So the first thing, I'm going to try to break this down for you a little bit, but when I see things like this, I get a little bit overwhelmed, and it takes me a really long time to go through it and really make sense of it. So this is going to be quick, but again, this is on the ACEs Aware website, and you can, you know, look at it in more detail there. So you have to decide who is going to give out the screener, right? So it could be the front desk, or it could be someone who's clinical. Depending on who you decide, it can change the workflow a little. So let's say the screening is given out by the front desk, and then it's returned to the front desk. If it's filled out completely, the front desk either gives it to a clinical staff, maybe like an MA or a nurse, who score it. But I mean, it is possible that the front desk people could also look at it and score it. At that point, if a paper form has been filled out, somebody, whoever is doing, I would say, the scoring of it, would probably need to scan it into the electronic health record, or they can wait to do that later. The main thing is that the provider needs to have the final score and the screener before they see the patient. That doesn't mean it has to be in the electronic health record, but you need to know, you need to figure out what works best for your practice. Is a provider going to actually look at something that's given to them on paper, or is it going to kind of get lost in the shuffle? And we definitely don't want it to get lost in the shuffle. If the patient doesn't fill it out completely, the provider also needs to know this, right? If the patient doesn't fill it out, somebody can inquire why, right? Or ask if the person needs assistance. And again, like we said before, this is all after we've explained it again, what this is for, what the rationale is, and how the information is going to be used. So assuming it's filled out, the provider reviews the score with the patient and then offers the appropriate intervention or education. And we're going to get into that in the second half. So I'm not going to go over really what that is. But I do want to stress that the Surgeon General in California really believes that even education around how trauma and this chronic stress impacts physical and mental health is an intervention in and of itself, and that can be very illuminating and therapeutic for somebody. So the provider must enter the ACE score, obviously, the correct billing code and treatment plan in order to get paid for this. For pediatrics, which it's the one from pediatrics and adults are really not that different. But for pediatrics, if the child is 12 or older, they can fill out the forms themselves if they're able to. Angie and I have had a lot of conversations about whether or not this is realistic, and I'm not sure that we've come to a 100% agreement. And I have a 12-year-old, and I was thinking, I should have done this. I should have given it to him to see like what his response, or how he would react to this. He could definitely fill it out. He could read it. But again, I'm not sure how realistic it is. But in theory, they could fill it out. If not, a parent or guardian can fill it out, which is another challenge, right? Presents another problem. So having a parent or guardian fill it out really presents some unique challenges that, again, we're going to discuss later. I'm sure you might have some thoughts about this. Either chat them in now or hold off until that section, right? But obviously the preview is that a lot of the things being asked about are things that a parent may have deliberately, done to a child, and are they going to disclose that, right? Okay, next slide. So this workflow for adults is essentially the same, except this one this really should always be filled out by the patient. Again, this may present some challenges if there are patients who maybe have health literacy challenges, maybe have disabilities that wouldn't allow them to fill it out. So in the best practice is that really a staff member should help fill them out, and not, the person that they brought with them, their support person or their home health aide, or whoever or their neighbor. That person really shouldn't fill it out, but we know that happens too, right? Okay, next slide. So obviously workflows can change and vary by practice. The main thing is to involve the people who are actually involved, right? And you want to keep track of how it's going, both formally and informally. So both counting, using quantitative data about screening and the process, as well as qualitative data that you're getting both from staff really and from patients. Really getting feedback from patients should be really important here. You may want to use the Plan, Do, Study, Act tool. If that's not something you're familiar with, don't worry about it. We can give you some resources on it. And it's a fairly simple tool to use. You want to set realistic timeframes to implement and assess. I guess best practices say somewhere around 90 days, but obviously if you implement something and within the first week you realize it's not working, you need to go ahead and obviously amend it. So just some ideas of things to measure, to keep track of, and there are other things as well. Number of people screened versus how many actually qualify for screening, right? This can give you a sense of the capacity, right? How well are you doing? Who is doing the screening, right? So if you've trained, let's say, 3 or 4 different people, who has been doing it more consistently? How many screenings and results make it to the doctor or the provider versus how many that don't? And then also another idea is how many screenings are complete versus how many are incomplete, right? And then thinking about, why that is, getting the feedback from patients and staff about why they think that is. So just some ideas there. Next slide. Okay, now on to the screening tools. There are a few different tools depending on who you are screening and what kind of screening you want to do, and we will try to walk you through this, or I will try to walk you through this. Next slide. Okay, I'm hoping you can see this. So this is the pearls identified for children. Yes, okay. So this screening tool, the pearls, is a validated tool, and it's really a combination of the ACEs screening, the original ACEs screening. It's been amended a little bit, along with social needs or social determinants of health. So the rationale for this is that obviously social determinants of health are also impacting health, and that many social factors like things like poverty and racism are traumas in and of themselves that people are experiencing, chronically or, and in the moment. I actually do a lot of training around social determinants of health and screening for social needs. So this is my preferred screener because it captures, both of those things. And it's really a baseline. People, when people are responding yes to the social needs pieces, it's really just a way to open up the conversation. You may still need to get more information from them. Okay, so the term here, this is really interesting. The term identified here means that the people who are filling it out check off the actual traumas they experienced as children or for the children, so that we know exactly what, is it abuse, is it separation from a parent, is it, whatever. And the other way it is de-identified, which we'll get to it in a moment. The identified, obviously, we're going to talk about, has some benefits because it obviously tells us, you can't see it, someone's saying they can't see the pearls. I don't know if there's a way for us to make it bigger. We could, in a minute, I could, or Angie, if you can get on the internet and maybe just go to the ACEs Aware site, find the screener and send a link in the chat. Sorry about that. It's hard to get these things perfect on these PowerPoints. Okay. So let's go to the next slide. Okay, so this is the same exact screener and the same tool. However, this is de-identified. As you'll see on the first page, there are no check boxes after each item. The way that this is meant to be filled out is that a person doesn't have to indicate which thing that their child has been experiencing, rather just how many of them they've experiencing. You're probably wondering how to decide which to use or which one's better. We were wondering the same thing. We'll be discussing this shortly, so hang in for a few more minutes. However, you'll see that on here, even though the trauma piece is not asking for specifics, just the number, the social determinants of health piece is identified. And this really should be the case always, because we really need to know what people are struggling with in that moment, right? It doesn't really help us overall if you say, yes, I have 3 social determinants of health or social needs, but we don't know if it's housing or food or legal or, other things. Okay, next slide. Okay, for teens, right? So this one is, and I think just to let everyone know, I think Angie was able to put a link in the chat box. So if you want to pull that up to look at the screener, you could do that as well. Some of you may have 2 screens. So this one is for teens and it's identified. So this one is meant for the caregiver to fill out. There is also another one that is a teen self-report, and it's actually de-identified with de-identified social determinants of health as well. I don't particularly think that is super helpful, but it's an option. And the only thing to note about the teen one being a little bit different is that there's also questions about incarceration and teen dating violence, which is a little bit different than the other versions. And we're actually happy to see that in there. Okay, next slide. Okay, these are the 2 straight ACEs screening tools that I mentioned earlier. So there are 2 versions. There are identified and de-identified. The first one you see here is the de-identified. So same thing, right? You just, people are instructed to just count how many of these things they've experienced, and then they can put how many in that final box. So is it 2 things that have happened? Is it 4 things? Is it 5? And then the next one is identified. So we're getting the information, the specifics. Okay. All right, next slide. Okay, so here we go. Which one to use? If you have a specific question about your practice, we're happy at the end, we're staying on just as a reminder if you want to talk about it. Otherwise, we're just going to walk you through a couple of high level things to consider. So the benefits of the identified screener is obviously that it can provide more accurate resources and referrals because it's more obvious, right, what is needed. It can help you as the provider or the practice more fully understand the patient. It could actually be validating and therapeutic for the patient. One thing that's really interesting and important to note is that even disclosing or discussing the experience can actually be therapeutic for patients, almost like an intervention on its own. Also, if there's an immediate threat to safety, the right safety intervention can be applied right away. So the benefits of the de-identified screener is that it can actually provide more privacy for patients, right? They don't have to think about or disclose the specific experience, rather just that they had them or they had something, right, in the past. With patients who may be a little bit more uncomfortable or unwilling, this may help them be more likely to get an accurate score and participation because they don't have to disclose the specifics. Especially for practices that are just starting this could also be less overwhelming for staff or people who are new at addressing trauma in a healthcare setting. You could always, right, start with the de-identified and kind of work your way up to the identified. It may be less triggering for patients to disclose, and it really actually does give patient more control of the discussion because they can decide, you know, if and when or how much, you know, more specific information they want to disclose. Okay, next slide. Okay, now we're going to talk about screening scores and risk assessment. So next slide. Okay, again, this is on the ACEs Aware website, and this is where we took it from. So if the ACE score is 0, the patient is at low risk for toxic stress. One thing I want to note before I get into it is that the social determinants of health portion is never included in the score. That stands separately. But it's obviously still really important to think about which ones are a likely trauma and could be causing toxic stress in the patients. So if the ACE score is 0, the patient is at low risk for the toxic stress. So the provider could offer education on the impact of ACEs and other adversities on health and development, as well as some of like the buffering factors and interventions, right? Just some of the healthy living stuff, good sleep, you know, as good a diet as possible, exercise, mindfulness, things like that. If the ACE score is 1 to 3 without an ACE-associated health condition, the patient is at an intermediate risk for toxic stress. If the ACE score is 1 to 3 and the patient has at least one ACE-associated health condition, or if the score is 4 or higher, the patient is at high risk for toxic stress. In both cases, there needs to be some sort of education or intervention. What that is, we're going to have a whole section on that shortly. However, I do want to say that we do need to be careful with pediatrics with these associated conditions because we're not expecting children who are going through some of these traumas to have the same health conditions as adults, right? They may not be obese yet. They may not have type 2 diabetes. So with children, you're more looking at things around potentially behavior, right? Maybe they're acting out, you know, I put that in parentheses, in school. Maybe they're having trouble sleeping. Maybe they're having trouble concentrating, right? Maybe they're, you know, getting in arguments or fights a lot. So different, those are the kind of the different things you want to look at. Okay, next slide. So this is really essentially the same as pediatrics, except obviously as an adult, we may see some of these associated health conditions that we talked about earlier. However, it also depends on the age, right? Maybe a 25-year-old, even if they've had lots of traumatic experiences, they may not have some of those physical health conditions yet. That doesn't mean that we don't want to, address and support that person. Okay, next slide. That's you, Ange.
So, so now we're going to move into, once you are, and hopefully you're starting to think about what type of screening tool would make the most sense, and maybe even thinking about, how this would flow within your practice. Now we're going to talk a little bit about, how do you actually implement the tool, and, work with the patient on the results. Next slide, please. Yeah, so I know that I keep harping on this trust part, but I think we can't emphasize this enough, right? Because it is so deeply inherent and deeply rooted in traumatic experiences, especially when we're really talking about things that have happened earlier in life, right? So these things happen during development. And so it is not, a matter of choice of trust, but trust is associated with safety and threats, and really will kick in that reaction that we all have, which is that fight or flight response of when we're trying to assess for danger, right? So this goes down to a very cellular level. So building trust and maintaining trust is so essential. And that's really what we all want, right? With our healthcare providers. But it's especially important when we're thinking about people who've experienced early trauma. So some of the things that will be harmful, that could be re-triggering, that could be re-traumatizing for someone, or interactions that are humiliating, feel impersonal or disrespectful, right? Encounters that are rushed or abrupt can definitely exacerbate those feelings. Thinking about tone, right? So tone that is demanding or judgmental, condescending, or aggressive or authoritative, in its tone, whether this is written or verbal, even if there's instructions with the screener that aren't being conveyed in person, to really just keep in mind, does this help to build trust? Lack of mutual collaboration, alienating and complicated language. So Yael was talking a little bit about this earlier around health literacy and how important that is, right? And so thinking about the language that we use, and, are there ways that we can break down instructions, or even the conversation so that it's in plain language and easier to understand and to digest. And ultimately, right, feeling unsafe works against trying to establish this trust. So what would make someone feel safe and what would build trust? Well, basically the opposite in a lot of these situations, but interactions that express kindness, reassurance, acceptance, right? An environment that is patient, that is calming, frequent use of words like please and thank you, verbally and written. We want to acknowledge a person's ability to make choices for themselves, and we want to really do things and use language that can be re-empowering, that really allow a person to feel safe because they feel that they have an option, right? When we start to take away those options, we start to really make a person feel cornered and threatened, and that will work against what we're trying to establish here. Active listening and plain language, all of these contribute to feeling safe. And obviously that's where we're trying to go with all of this. And then providing options. And of course, there are a lot of other things, but this is really a baseline to start to think about what the environment is like, what is our tone, what's the language that we're using, how do we interact with our patients, how are other patients interacting with patients, and really wanting to think about this in all of our interactions, whether it's over email or text, on the phone, or in person, or in writing. Next slide, please. So communication is, I don't know about you, but I feel like I've been hearing this since, I don't know, the time that I was maybe before my first job, right? It's all about communication. And every day I'm reminded of how true this is. So in this particular situation, what we're talking about is communication, where we want to speak slowly. A lot of these examples are thinking about in person, but that they can be translated into nonverbal, unwritten, or over or virtually as well, right? So we want to speak clearly, slowly. We want to speak at an appropriate volume. We really want to follow the lead of the pace of the patient that we are working with in that present time. We want to use the preferred language of a patient and not make assumptions. If you are working with a patient that is multilingual, let's not make assumptions that just because a person can actually speak in a specific language, that's the language that they feel most comfortable in communicating in. We want to use ORs from motivational interviewing, right? So open-ended questions, affirmations, reflections, summaries. We want the conversation to be open. We want to allow for opportunities for people to ask questions, for people to reflect, for people to really absorb what we're asking them to do with the screening. We always want to appear engaged, pleasant, calm. These are not always easy things to do, and that's why we're writing them in this PowerPoint, right? It's really hard to do this when we have a million other things that on our minds, or we have a full patient roster that day. So again, this is also just a really like a self-check-in for ourselves. Are we able to do this, as a practice, but also individually? And if we're struggling with any of this, what can we do, to make sure that when we're engaging with patients, this is what we're conveying. Avoiding sudden movements, keeping hands out of our pockets. We went into a lot of detail in the last webinar around how to perform a trauma-informed examination. We spent a lot of time on communication, and definitely, if you didn't get a chance to see it, you can go back and look at some of those tips there. And most important, pay attention to patient cues. When we're really caught up in reading from a script or keeping up with our EHR, those are missed opportunities of really being present and picking up on what's happening with that patient, what their body language is like, what their eye contact is like, what the tone of their voice is like, their facial expressions, and how tensely they may be holding their body. Next slide, please. So how do we actually implement the screening tool, right? And Yael really set the stage so well for us earlier, right? Number one, we want to make sure it's by trained and prepared staff. This is not the time where someone can just step in if they're not familiar with the screening tool, if they're not familiar with what we're really trying to accomplish with screening, right? We want our staff and our colleagues to feel confident and comfortable with this, because that is what will be conveyed to our patients. We want to make sure that we have privacy for our patients and ample time for people to complete these screenings. They may be, just 10 questions, but if you take time to really review these screening tools, these are really big questions that we're asking people to reflect upon. And if some people may not be ready to really reflect that long, but we want to give the option for people to really think about it and decide how much they can or want to share. If we're using a telehealth modality, definitely make sure that you are aware of privacy and comfort level of patients before doing a screening. And we just put this in there given, how we're all operating now in the pandemic. So it's definitely possible to screen virtually, but that's definitely something that you need to consider, and what else you're doing through telehealth, right? Direct and clear and simple language is the best, especially in using screening tools. We want to keep it concise, clear, and not overwhelm a patient. But definitely leave the door open for questions or needed clarification. Compassion, non-judgmental communication, and the way that we speak with people is really important. I know, again, these are things that seem simple. And of course, ideally, we all are striving to communicate with everyone in our lives this way. But we put this here because, definitely when we're overwhelmed, if we're rushed, if we don't have a lot of time, we may not be aware of how we're delivering information. And especially, when we're talking about things like trauma, if you're someone who's used to talking about trauma in your work, sometimes it's easy to forget that this is could be a very foreign concept to most people and most of your patients coming in for care. We also want to make sure that there is an in-person opportunity to talk through this screening tool and the results. And again, using language that's most preferred by the patient. It's really helpful to start with some sort of a framing statement. And I think it's a great idea for you and anyone else who's on the team or in your practice or colleagues to think about what is going to be the statement that we're using, the language we're using to introduce this idea, so that it can be something that is normalized among your patient population. And to explain the reason why we're doing it. So we provided a few examples here. For example, because early childhood experiences can have a great impact on health throughout our lives, we are asking all of our patients to complete this questionnaire, right? It can be very simple. You can also go into a little more detail depending if you're the provider or the person who is administering the tool, but won't be reviewing results. So really giving the example that extreme stress or things that happen to us as children really can actually make us sick as we go through our lifespan. And that's also a reason why this might be happening in a doctor's office. Next slide, please. So these are some basic do's and don'ts of screening that are trauma informed, and you could apply this really to most screening tools that you are or may already be implementing in your practices. So we do always want to identify and validate existing strengths and protective factors that a person is already using in their lives, right? We do want to use motivational interviewing techniques. We do want to allow patients to fill out privately. If an adolescent and or an older child is able to and prefers to fill it out on their own, and that is who your primary patient is, we want to make sure that we're providing that option. We want to emphasize how the information will and won't be used. There can be a lot of hesitation and resistance to screening tools, especially when we're asking about such personal details in people's lives. Among all of our patients, but especially patients who have already experienced different forms of racism, discrimination, and other forms of oppression. And so we want to make sure that we are introducing the screening tool in a way that does not feel stigmatizing or that we are targeting a certain patient population, right? And so a lot of concerns may rise to the surface depending, around privacy, confidentiality, and just really, why do we want to know this? So really being ready to explain that in a way that is, straightforward, simple, compassionate, and also having time to really answer questions is important. We don't want to push or initiate a screening if you are working with a patient that is in distress over something else at that time, right? That is not the time to be pushing this. We really don't want to rush. When you are implementing the screening tool, we don't want to skip any screening questions. Sometimes that can happen because it's more around discomfort by the screening person or the provider or whoever is administering the tool, or our own kind of bias or projection around what may be uncomfortable for the other person, right? So we might skip one of the questions because we feel that it might be too personal or not apply to the patient. And that's really our own biases, right? So we need to be neutral and give our patients the option and the ability to choose for themselves. Don't doubt the validity of what is shared. So if we get a screening tool back and a person has a score of 0 or vice versa, they have a score of 8. We really, for asking people to fill these tools out, it is not our role to then question if what they're sharing is or is not true or real or accurate. Next slide, please.
Just a quick time check, Angie.
Got it. Thank you. And then similarly, when we were confirming results, right, you want to make sure that you have the tool that was actually used. So you want to make sure you know which one was filled out and the results when we're talking through this with our patients. Explaining the rationale again, you really can't just explain this enough and really making that connection. Again, going back to this idea that, trauma is a word that we're using so frequently now in healthcare, and that's wonderful, but it's also not something that people fully understand, in everyday life. And also, I think that for a long time, trauma really remained specifically in more behavioral health and mental health realm. And so that now we're bringing this into medical care, many patients may feel or wonder, well, what does this have to do with my physical health? And are you trying to say that this is something that's, in my head or just emotional? So really being able to back this up with science and research that, this all connects to our actual health. And it's not something that we're making up or because, we were upset too much by something as a young person, that it goes much deeper than that. Validation is so important in thanking a person for sharing or disclosing whatever it is that they were willing to. And then we want to definitely discuss the next steps. What's going to be done with this information and how does it really get translated into their healthcare plan with you? Next slide, please. So what else can we do? Well, we want to make sure we leave the door open, right? I was saying earlier, it's too bad that there are some limitations around billing and implementing the tool more than once, because for some people it may need to be administered more than once, depending on, what's happening in their lives, or maybe as the relationship within your practice develops. So leaving that door open and really, making that connection more than once, not just in that confirming results conversation, but how are you continuing to use that information that we now have in improving quality of life and also health outcomes with your patients? We want to always believe our patients. We also want to know, it's really make sure it's important to understand the laws in your state and local jurisdictions around mandated reporting and limitations of confidentiality. And we're going to talk more about this in a few minutes. But again, of course, because you may have young people filling out a screening tool that may disclose certain things that are happening in real time at home. Or depending on where you live, you may have an adult, or depending on their state, they may disclose things that will require you to consider having to make a mandated report. And then we really, really, really can't stress this enough, that connecting with your local resources and other agencies, and if possible, doing this, continually, to be able to provide warm referrals for additional resources, right? Because we're asking about such a broad range of possible experiences a person may have experienced, and definitely the social determinants of health, right? We're going to need to know about a lot of different types of resources and social service needs for our patients. And so you can't start too early in developing those relationships. And, we all hopefully will continue to learn, this is kind of somewhat newer, really, which is a funny thing to say. But we're really all learning about how trauma and how stressors, how toxic stress really affect our health and our well-being across, throughout the lifespan. Next slide, please. So again, this is another slide just if in case some of you are doing telehealth and you might consider screening through telehealth. The main thing through, doing things virtually, the most important thing is that, you're not in the room with someone. And so you can't necessarily pick up on certain cues that may be a little more obvious to you when you're in person. So that's one thing we want to just be mindful of doing anything virtually, that we are really emphasizing our own, communication, body language, what we want to convey, and that we're really paying attention to what we're seeing and hearing from our patients. We also really want to emphasize the importance of safety for patients that we're working with virtually, right? We don't know who else is in the room. We're all using different types of platforms, and everyone has a different type of, expertise or skill level in using them. So think ahead as far as what if you get disconnected, all of a sudden, how can you reach that patient easily? What do you already know about that patient that you need to consider if you're doing a telehealth visit, so that you don't put a person in a more compromised situation around safety? And I'm specifically thinking more around things like abuse or neglect or domestic violence that might be happening in the home. And always, follow the patient's lead and really giving over, making sure that patients understand that they can really direct where the conversation goes or doesn't want to go. So we're happy to discuss this in more detail with you if you want to stay on later, but this is just a very simplified set of tips. Next slide, please. So challenges with the screening and using tools. And I'm sure many of you have been thinking about this already as we're going through these. But we did want to just note some of the probably more obvious challenges and, and just to make people aware and thinking about this ahead of time so that you can also troubleshoot and how to overcome some of these possible challenges. Next slide, please. So we broke this up in working with adults and then working with children or minors. So some of the potential challenges with adults are that, presenting or introducing this screening tool may reinforce some of the distrust of healthcare by communities of color and or immigrant communities, especially, right? So that again, it just goes back to what I was mentioning before, that we don't want to reinforce stigmatization, and we certainly don't want to contribute to what has already been, a very long-term distrustful relationship among people of color and in the medical field, right? So again, it's all about transparency and communication and how we set the tone and the stage from the beginning to really be able to mitigate some of these things, even if they're unintentional. And then also open up the door, let those conversations happen. If someone is concerned, allow that conversation to take place and be able to, rather than minimizing a person's concerns, really addressing what you can about those concerns. If the screening is not well explained, we're going to get inaccurate results, or maybe a person's resistance to even filling this out. And again, if providers don't ask all the questions during the screening, and we have heard some of this in the past a lot around that. And I think for both of these points, they come down to just the comfort level and the preparedness of whoever is implementing the screening tool. Health literacy issues. So if people can't fill out the forms and don't receive help or assistance, then again, it's going to really stand in the way of what we're trying to do. If the screening scores are not received by the provider by the time they see the patient, that can certainly lead to some real issues, right? And not just kind of the obvious issues around efficiency and effectiveness, but also what does that say to the patient that we ask them to do this and we're not able to talk to them about it? And Another potential challenge might be, how do we take this and incorporate it in a way that is relevant and matches the individual patient, right? We certainly don't want to start implementing screenings to lead to kind of over treatment or unnecessary referrals and diagnoses, right? This is supposed to help improve quality of life for our patients, and we don't want to do the opposite by just adding a whole other list of problems and issues and additional follow-ups that they need to have. So really weighing that balance and preparing ahead of time of what does this mean for our patients. Next slide, please. So a lot of the challenges and concerns for children and teens are the same. And then I think that probably something that many people may be wondering, and Yael mentioned this earlier, about what happens if a minor discloses something on the screening tool that may require further questions or a possible reporting, right? So the potential challenge or benefit, depending on what it is, could lead to increased reporting to Child Protective Services by raising suspicion. And this could be a challenge or it could be a benefit, right? I mean, this also is an opportunity to intervene in truly unsafe situations. But again, we need to be prepared and know what that process is within the practice so that we don't have this knee-jerk reaction of over-reporting. And then, another challenge with young people is what happens if it's the caregiver who's completing the screening on behalf of the child. Will there be, will they withhold some information, or will they just not be able to fully, speak on behalf of the child or the teen, right? We all have different experiences. And so the perception of the caregiver of what's happening in the home versus what the individual child or teen is feeling in the home might not be the same thing. Next slide, please. So what do we do if if our patients do disclose trauma histories, which will most likely happen because we know that a large percentage of the population have experienced at least one of the ACEs on that screening tool, if not two or more. Right. Next slide. So I think the first thing that I just want to say is that this may be the very first time in a person's life that anyone is even asking about any of these things, right? When you're an adult and you go in for healthcare, it has probably never happened that someone is asking you as an adult what your life was like up until you were 18, right? To understand your health better. So this is an amazing opportunity, right? But it will come with some challenges. So we want to make sure that we're acknowledging, validating, and educating with everyone, right? Education is so important and can be an intervention in itself. Preventive as well, right? We're going to provide referrals and support services and resources around social determinants of health that make sense and that are needed. And then creating and modifying a care plan, incorporating the risk level and screening results, right? Next slide, please. So some things that you can say immediately is thank you, right? We care about you. And then also talking about the things that you have been concerned about, as far as their health or their health outcomes, and then, making that connection between what you may have learned through the screening result and what those concerns are. You'll discuss referral options and appropriate resources. And I will say that most of the time they will just be optional, right? Most of these trauma disclosures are going to be things that happened in the past that are part of the past. As far as what I mean by that is that they're not necessarily going to require an immediate crisis intervention that's dealing with safety, right? And so that really does give you time to work with the patient, to discuss things with the patient, and to really learn what types of resources are they already tapped into and what might help to supplement or complement what they're already doing, right? And then in situations where mandated reporting may be necessary, you are going to want to explain that reporting obligation, right? It should never be something that catches a patient by surprise or done in secrecy, right? We want to go back to that trust building again. Share the reasoning, and then, if at all possible, create that plan with your patient together, right? So if it is a situation where children's services need to be called or the police need to be called, it can be done with a patient. It doesn't have to be done aside from or without the patient, okay? Next slide, please. So things that we don't want to say, which I think are probably more important, right? There's no perfect response. What's most important is to respond authentically and genuinely and with enough patience that you can, be in the moment. What we want to avoid, though, is we want to avoid making excuses or rationalizations about disclosures that were shared, right? And that's kind of a human reaction when people share something that sounds painful or are upsetting. We want to make them feel better, right? We want to fix it. And certainly in the healthcare world, right? We all probably have gone into patient care because we want to do something about it. But what we really want to do is just allow the person to share and thank them. But really, we're not going to need to rationalize or explain further what happened. Everyone who's experienced a traumatic trauma in their lives already knows, right, what has happened to them. What we want to do is just validate whatever is shared and how they are feeling, but not to tell them that they shouldn't feel that way. Be mindful of labeling or stereotyping based upon the results of screening. And then, really just pay attention to your own body language and facial expressions, because we don't want to react with shock or alarm that's written all over our face, or pity, right? Compassion, absolutely. It's okay for you to feel, have empathy for if a person is, sad when they're sharing something, for example. But we want to keep things open and we don't want to shut off. So any sort of communication or words or body language that may force a person to kind of put that wall back up, that's what we're trying to avoid. Next slide, please. So again, really the
Check, Angie.
Thank you. The additional considerations around high risk or acute situations. So this is really first and foremost, right, it's patient safety, and that's with everything. If you are implementing a screening and this screening somehow has triggered a person, or going through the results, they have disclosed something where they are in danger because of someone else. So for example, if there's a disclosure with children or minors where there may be violence or neglect in the home, right? Then we want to consider, is this person in danger? If an adult discloses that they're in danger of possibly wanting to hurt themselves or someone else, or are experiencing domestic violence or sexual violence, in certain states, that could be a mandated report, right? And then we also just want to consider confidentiality. And again, what is that conversation for you in your practice? How do you introduce the idea of privacy and confidentiality with your patients in general, right? Because there are times where that we can't completely keep things private, right? So for most, I think, patients, this will not be surprising necessarily, but I think we just wanted to introduce this because whenever you're kind of introducing a new tool or starting conversations about things that have never been discussed before, to anticipate that there may be disclosures that will require us to act more swiftly and really around safety measures. Next slide, please. And I just mentioned these things. So again, I know people are calling in from all over, which is amazing. I think for child abuse and neglect, the standards are pretty similar across the country, right? And healthcare workers, anyone in healthcare working directly with a patient, there are mandated reporting laws. And then around sexual and domestic violence that may either be disclosed by a child or a teen, or an adult. In some states, these are also mandated reports. We know in California they are, and so it's good to be aware of that. And again, to just anticipate how those conversations will happen with your patients, and how can you do it so that it's not triggering, but that really emphasizes it's for the safety and well-being of your patient. Next slide, please. So we get to the part now of, well, what else can we do? What else is out there to support patients who have a trauma history? Next slide, please. For adults, a lot of this will obviously also come in education, which can be so helpful. And we've taken this, actually, most of it from the acesaware.org website. So I won't read this list exhaustively. What I will say, though, is that around trauma, really what all of the approaches to trauma really are about is building resilience, right? Buffering toxic stress that may continue to exist, especially within considering social determinants of health. And what are the things that we can do to promote overall well-being with our patients that can help to mitigate the impacts of this stress, right? So everything from eating healthy, regular sleep, and how important sleep is. And we're seeing that more and more with recent studies around sleep and COVID and our risk to even that virus. And this is going to look different for everyone, right? Next slide, please. So everything from things that help to engage a person with the outside world, hobbies, socialization. So, right, going back to that trust building, and that trauma often breaks that connection with ourselves and others. So all of these recommendations really are taking that into consideration, right? So things that may be things that bring pleasure, things that bring positive feeling, things that can counteract stress, things that connect us to community, to support. All of that helps to build resilience as well, and really helps to counteract that feeling of isolation and aloneness that most people who have trauma in their lives carry around with them. Next slide, please. With children, obviously some things will be different and some things will be the same. Again, we still want that connectedness. We want to connect children with support. We also want to help children with additional outlets on how to express what they're feeling when they may not have the words. So journaling can be really helpful. Artwork can be really helpful with adults and children. And quite frankly, all of us right now, what we're all living through, working on breath exercise and grounding techniques really help us to slow down our heart rate and really help to resist that, the triggering of our fight or flight reactions, which is really what, a lot of that stress is coming from, and also what eventually can lead to disease. Next slide, please. For babies and toddlers, we wanted to just mention and point out how important attachment is. And when trauma has happened to someone very young or in their developmental stages, depending on when it happens or by whom, so if it was from the parent or the primary caregiver, that's what we're seeing. We're seeing a disruption in attachment. So what we want to do for well-being of toddlers and babies is how do we emphasize and how do we strengthen attachment? And that really will require working with the caregiver, right? And the baby or the toddler. But that what happens is when there's a stronger attachment, it really sets up protective factors for all other stages of development for children. And then eventually, right, we see that positive impact as adults. Next slide, please. And this just goes through some of the list, right? And as you can see that the benefits of strong and healthy attachment really are the foundation for the whole person. So when you have a strong and healthy attachment, it helps to build self-confidence, our own self-worth. When we have that confidence and self-worth, then we have more ability to interact with others in a positive way, right? And when we have successful social interactions, then that helps to build the self-worth. So, right, so you see it's a cycle and it's a foundation. And when you have that strong foundation, it sets everything up. And then conversely, when you don't have that foundation, it then starts to become a part, and really we start to see it in all areas of life, right? So for children, we might see it with problems with learning or paying attention, getting along with others. We may see kids that are, quote unquote, colicky when they're babies or infants, but really what's going on may be much more deeper than that. And then eventually we may see withdrawn behaviors or aggressive behaviors. Next slide, please. And then last, but not least, and I would say that those other slides also are considered, therapeutic, quote unquote, approaches to addressing trauma, because it's not just a one thing, right? And that, you can't treat trauma, right? We don't treat sexual abuse. We don't treat, a neglectful parent. We're treating really or addressing what trauma has done to the overall person, right? And so there are many things that are going to be going on with patients all at once. And so identifying trauma in a person's life and a person kind of confronting or addressing that trauma is not going to just fix everything. But again, it's a foundation. And so overcoming trauma really requires action, right? Effective action, accessing the emotional brain. So when we work with patients and patients find ways to not be afraid to feel what they're feeling, that's a first step in really being able to sit with themselves, to incorporate the trauma so that trauma becomes a part of their life, but is not what's dictating the way they live their life. And so there are a lot of different clinical modalities through therapy, and I listed a bunch there on the left-hand side. There's some newer ones that are very, very effective with trauma survivors, but we also see things like body work, so getting connected to a person's body, breathing techniques, even things like Reiki and acupuncture are helpful in addressing trauma and not just specific, right, like pain. And then of course we know that medication can help and supplement a lot of this other type of work and support. And it's not a one size fits all. And so every person's going to be different. So it's just really useful to know that there are a lot of options, in that just beginning this dialogue with a patient can really open the door to a lot more opportunities for people to feel better. Next slide.
Okay, so we're reaching the time limit, but just quickly, thinking specifically about small practices, most of what we covered is really applied to everybody, or really any practice, right? But particularly in small practices, if staff play multiple roles, they really need to be clear about their role in screening and response so that we don't confuse patients. So for example, if you're the medical assistant, but you also sit at the front desk, and you're going through the screening with a patient, you definitely want to explain what your role is in that moment. Some of the benefits, you may know your patients better than larger practices. So you have the perfect setting and the foundation upon which to implement screening and trauma-informed care. Knowing and using your community resources, oftentimes because you don't have as many resources, you've had to establish relationships with other services in your community, and you're already ahead on that game, which is great. And getting feedback from patients about those services is really, really key, so that you actually know exactly what people will experience when they use it. Obviously experimenting with multiple workflows if needed. There are really many ways to do this work. And, you know, bigger practices have their own challenges, smaller practices have theirs. And it's just, you know, about trial and error. And seeking out free or low cost professional development. I mean, especially, you know, through ACEs Aware, there is so much going on. I can't even keep up with it. So, you know, and I believe that the work is going to continue. It seems like it might. I saw some sort of email coming through on, you know, extending some of these resources and trainings. And so, you know, seek it out. You don't have to spend a lot of money right now. Next slide. Okay, I'm gonna, just for the sake of time, I think I'm just gonna skip, you know, remembering Ralph, but, you know, we're thinking about, you know, Ralph a little bit. So we're gonna move on to questions. Just one thing really quickly. We are taking the information that we have in these webinars and we are moving them into a practice paper. So it will be like best practices for small practices. So we're actually looking to interview a few small practices, and the way we're defining them is around 6 or 7 providers or fewer. You can be part of a larger system. Like, for example, if you're working at a federally qualified health center with 9 sites, but each site maybe only has 4 providers, then that would be fine. So we'd love to interview you. The interviews will take about an hour to an hour and a half. And we'll give your organization a small stipend. So if you're interested, please either let me know in the chat box with your email, or please reach out to me directly at ylipton@pcdc.org. We really want to hear about how things are going and what, you know, and be able to share those learnings with, you know, the broader state as well as the broader country, since we're a national organization. Next slide. So we're staying on. Feel free to, you know, chat questions and or, you know, ask, and we'll be happy to stay on. Thanks for hanging in for the time.
Oh.
Nothing? Oh, there's a couple.
Oh. Yeah.
Someone's asking, what were the resources again to address resilience?
Oh yeah. So well, there was good information, and a lot of that what we put on there for the solutions for adults and children, that was from the acesaware.org website. And then but there are a lot of really great you know, I can't recommend The Body Keeps the Score enough. It, you know, it does talk about a lot around just trauma, but it also talks about resilience and how that works. And that's by Bessel van der Kolk. And he's probably like the, you know, the world-renowned expert on trauma. So I really suggest reading that too.
Someone's asking, and I'm hoping maybe Amy can address this. Once screening is done, besides scanning in the screening form, do you recommend, or how do you recommend recording this in the problem list, right? So that people, so that the information is there when you open the chart and you don't have to dig too far. I'm assuming that's what, Drew, that's what maybe you're asking.
Hi, Drew. Yeah, I think that that's a challenge, because when you put something on your problem list, you're going to be addressing it. Is this something that goes on to maybe a progress note where the patient can see it? If it's something that's coded as some kind of social determinant of health, all of those considerations to be thinking of. It is possible to be putting that information there. It's just a matter of who has access to see it. Is there sensitive information? You want to be mindful of those kind of considerations. I hope that answers your question. If not, let me know.
Amy, is there a specific place in the chart that you think it would be better aside from a problem list? Because I don't like it. I don't like it under the problem
I
list.
mean, I think it depends how your chart is laid out, because every EMR is different. If you're trying to have it be in a place that is readily accessible to providers, then maybe there should be some kind of coding system that's on a template for the demographics, or something on an intake template where it's something that you see, or a summary template or a title bar or something, without knowing the type of EMR you're using. And also there are so many out there, to tell you the truth. I've only worked with a handful. I think that that's something maybe that the practice could discuss, where might be the best, because it's also part of your workflow. So it's not just, putting it on the EMR and hoping for the best. It's about having people know where to look and know how to use that information. So I think those two pieces are things that the practice operationally should discuss, to be able to figure out what's best for them, because what's best for them might not be best for someone else or another practice.
And then there was another question, is there a particular diagnosis to put in the chart? I don't think that there is a trauma diagnosis.
So I would have to look up to see if there is some kind of social determinants. There are social determinants related to housing circumstances. There might be something, I don't know offhand. I haven't really delved too deep related to domestic violence or sexual abuse or any kind of ACEs related conditions that are trauma related. But I would say that let me get your email address, and we can email you to see if there's something SDOH related that would be appropriate. Another answer might be to see what ACEs has and how they address that issue on their website, or if they don't, Yael, you're shaking your head.
I've never seen a diagnosis. I think because all of the there's so many diagnoses that the trauma has contributed to. So I don't think we want to put that I don't think it's ever really put as a particular diagnosis, but
there are Z codes. There are Z codes, which are what you would look up to see about social determinants of health, relational problems, relationship distress with spouse or intimate partner violence. There are codes that you can look up for the ICD-10, the Z codes for some kind of personal history of adult physical sexual abuse. There are definitely codes that would reflect this, but you'd have to be very specific. So you'd have to really know exactly what's going on with that patient to be accurate and appropriate.
Yeah, that might be a lot to dig into.
But there are Z codes. So there's a whole slew of them that relate to all of this. I just looked some up.
Thanks, Amy. It's so helpful. Drew will reach out to you with more information. Anyone else? All right, I think if no one has anything else, we'll wrap it up. Please fill out the evaluation if you can. And we will hopefully see you next month. And we will also, you'll be getting an email in the next probably day or so that will be coming with the recording, as well as the links to the previous recordings. But we just wanted to say thank you so much for being here with us. It's always a great way to spend a couple of hours and keep up the good work.
Thank you.